So I'll be talking on how to maximally trace an information from CT pulmonary angio report. And it has been a recent ESC update from 2025. And so being a clinician, though CT pulmonary angiography reporting is a task of radiologists, but now in this today's era, now as we know, the POCUS primarily was considered a radiologist domain, but now we do well. So in the same way, we also should know how to interpret some CT scans, like CT pulmonary angiography, some CT scan of chest, CT abdomens, MRI imagings. So that's why there is one consensus which has been published recently means 2-3 months ago only. And this is the first time in the history happened that 8 societies have come together to have a recommendation on how to report a CT pulmonary angiography report. So now, for this, why this consensus statement is required, first of all. CTPA is the most used diagnostic test, but there are no clear-cut recommendation to which points to be included in reporting CTPA, and that's why the need for a general guideline or consensus throughout the world how to report this CTPA report and which points to be included. Goal is to standardize terminology, required findings, and reporting structures. Primary goals of statement are define scan techniques and quality targets and provide consistent definition and nomenclature. List core CTA findings that must be reported and create a practical image atlas for teaching. Now, as it is a radiology article, there are so many technical things related to radiology, like how much contrast to be given, how patients should be kept. So that technical part I have not included. The clinically relevant important information for us as a clinician or intensivist or physician, that relevant information only I have included here. So takeaway points are scan settings, right? So that we need to know. Use the highest temporal resolution and the shortest rotation time. Entire thorax coverage in less than 1 second possible with high pitch modes. Prefer low voltage 80 to 100 for higher iodine contrast plus low radiation, and use iterative or deep learning reconstructions to reduce the noise. Then contrast protocol 80 to 100 ml at 3 to 5 ml per second injection. Prefer 350 milligram per ml, so in a high concentration for a better opicification. And use anticubital vein 80 to 20 gauge or fenestrated 20 gauge. And breath holding. When we will be screening an acute dyspneic patient in pulmonary embolism distress, it will be difficult for them to hold the breath. So in dyspneic patient, it is better to go for deep inspiration or shallow breathing and avoid Valsalva maneuver as it can transiently interrupt the contrast. So these are the things. Now, special population like in pregnant individual, how to do? Obviously, the radiation dose should be kept minimum. It should be screened from cordiocranial scanning. The scanning should be started from the leg end to reduce the breast radiation exposure and higher flow. Instead of 3 to 5 ml, we have to inject the dye at the higher rate, at 5 ml per second due to increased blood volume. So that the exposure time in CT scan will be quite minimal. Now, standard nomenclature for reporting. So there are some definitions, there are some nomenclature we already know. Acute pulmonary embolism. What is that? Central filling defect, acute angles with the vessel, within pulmonary arteries that essentially retain the cylindrical shape of the dislodged thrombi, which either may remain intact or may fragment on their way through the heart. So this is the acute pulmonary embolism. Then it also includes complete arterial occlusion. This whole pulmonary right main branch is occluded with the thrombus, and here high chances of mortality, high chances that even though we thrombolize, there is high possibility of some thrombus will remain inside. It may lead to CTPA. Then subacute or chronic pulmonary embolism, persistent filling defects after acute pulmonary embolism, and these are the filling defects. The cross section of these filling defects is thread-like. Remember the words terminology: thread-like, band-like, wave-like, or irregular, but not the round. If these lesions are round, then we are mostly dealing with the acute pulmonary thrombolism, and if we are dealing like thread-like, band-like, or wave-like, then we might be dealing with the chronic pulmonary embolism. So round cross section usually suggests recurrent acute PE, and this type thread-like, band-like like this, or irregular structure denote chronic PE. So this is the intravascular wave. These are the waves because of the chronic blood clots inside the pulmonary vessel, which will be, take the shape of waves, but not the round shape, right? Then embolus is a thrombus that has dislodged and is located at the site different from its vessel of origin. Incidental PE is a PE identity upon CT scan ordered for any other reason than suspected PE. In situ pulmonary thrombus is present as a wall adherent filling defect, usually in large or enlarged pulmonary arteries. Isolated subsegmental PE, subsegmental PE limited to a single subsegmental artery. Peripheral PE is located in a segmental or more distal pulmonary artery. Pulmonary artery filling defect means the pulmonary vessel will not be opacified at the location of the pulmonary thrombus. So whole pulmonary artery will not be opacified and it will look like a filling defect. But there are few other terminologies like pulmonary thrombosis, right ventricular hypertrophy, saddle embolism, subacute PE, subsegmental PE, and thrombus. That I will not discuss because I will recommend to refer the article for that. Now, core findings required to report CTPA. Though now there are 8 must to have and 3 likely to have. So what are these 8 must haves? The 8 must have a RV by LV ratio, central PE location in main or lobar artery, subsegmental PE isolated or not, septal deviation, intravascular waves or bands, pulmonary artery retraction, bronchial artery dilatation, and right ventricular hypertrophy. Means every CT pulmonary angiography report must write these, radiologists must write these 8 segments, whether the RV-LV ratio is how much, location is central or not, subsegmental PE or not, septal deviation is there or not, intravascular waves or bands are there or not, pulmonary artery retraction is there or not, bronchial artery dilatation is there or not, and right ventricular hypertrophy is there or not. Why? That I will discuss in the later slides. And nice to have pulmonary artery trunk diameter, organized mural thrombi, and complete arterial occlusion. So there are some images for all these 8 must-haves. So RV by LV ratio like this. Whenever we know RV is dilated in size compared to LV, as we all know in 2D echo, then RV ratio become, if it is more than 1, then mostly we are dealing with the acute pulmonary embolism and not the chronic one. Then, if location is central, main or lobar, then most likely we are dealing with the acute PE. Subsegmental PE, isolated or not, maybe acute or chronic. Septal deviation, mostly acute pulmonary embolism. Intravascular waves or bands, mostly chronic. So septal deviation will be looking like this. In echo in focus, also we can visualize this D-shaped LV. So LV remain convex towards the RV normally. If RV remain convex toward LV, then we are dealing with the acute distance. We may be dealing with the acute pulmonary embolism here. Then intravascular waves and bands, as I already mentioned, this is more likely of chronic PE and not the acute one. Then pulmonary artery retraction. This pulmonary artery is shrinked inside or retracted because of the this blood clots is inside the arteries remaining for the longer duration, right? So we are mostly dealing with the chronic PE and not the acute one. Bronchial artery dilatation, right? These are the bronchial artery. Now lungs themselves get their nutrition oxygen via bronchial artery, not the pulmonary artery, right? So that I also came to know by reading this article. So because of that thing, when the blood clots are remaining in the vessel for a longer duration, this bronchial artery will get dilated. And this is a sign of a chronic PE and not the acute one. And right ventricular hypertrophy, right? So this is the right ventricular wall hypertrophy. In echo, we already know that if right ventricular hypertrophy, if it is more than 4 mm, then we are dealing with the right ventricular hypertrophy. And it is suggesting of RV dysfunction. If it is developed acutely, then we are dealing with the acute pulmonary embolism. And if it is there for longer duration, then we are dealing with the chronic one, right? And now the nice to have 3 items, which are pulmonary artery trunk diameter, organized mural thrombi, and complete arterial occlusion. So pulmonary artery trunk diameter are, if it is pulmonary artery diameter is more than aorta, if it is developed acutely, then we are dealing with the acute pulmonary embolism. Organized mural thrombi is a sign of chronic PE. The mural thrombi is attached to the blood vessel wall on the outer wall. And complete arterial occlusion, again, is a sign of acute pulmonary embolism. Then, finding excluded IVC reflux, Canardelli score, and coronary calcium score. IVC reflux, when acute pulmonary embolism is there, reflux will be of contrast from RA to the hepatic veins or IVC. Then, Canardelli score is a quantified scoring of the load of the thrombus inside the pulmonary vessel. And there is a scoring. If main artery is the thrombus, then the scoring is 10. Then lobar segment arteries, the reading will be 1. For segmental, for each segment, it will be scoring will be given 1. So this is not required to report. Then why these findings matter? Because it has a prognostic value. So the predictors of short-term adverse events like death and shock are raised RV-LV ratio, more than 1, septal bowing, PA trunk dilatation, and central float location, right? And that's why it is important to report these findings by anyhow. Predictors of long-term complications like post-PA syndrome and CTPA are waves or bands, pulmonary artery retraction, complete occlusion, bronchial artery dilatation, organized mural thrombi. Clear? So now reporting standards. How our CT scan pulmonary angiography reporting should be done and which are the points that must be included by radiologists. So diagnostic component, presence or absence of pulmonary embolism, location of thrombus, clot burden description, RV parameters, pulmonary artery diameter, septal position. Then chronicity component like evidence of prior thrombus, waves, bands, retraction, CTPH indicators, and technicality, level of analyzability of pulmonary arteries, adequacy of contrast, and artifacts. Now, what are the artifacts that I will try to tell you in further slides. And also need to notify alternative diagnosis. Like patient might be having a pneumonia, aortic dissection, pericarditis, edema, malignancy, which can be diagnosed by chance on going for CT angiography. That also need to be notified in the report. Now, indirect signs of pulmonary embolism. So we all know there are some indirect signs of pulmonary embolism, and we learn these since ages in our MBBS or even medicine, like pulmonary infarct. It's a peripheral airspace opacity, like broad pleural base opacity. That is a pulmonary infarct, and these, even though those in CTPA, if we not find any pulmonary thrombus, and if we find this pulmonary infarct, we may be having a pulmonary embolism in a subsegmental peripheral level. Reverse halo sign or atoll sign means a central ground glass opacity surrounded by a rim of consolidation, which is also an indirect sign of pulmonary embolism at peripheral location. Then Westermarck sign, right? In XHS, we all must have read this. The classic sign of oligamia distal to an embolus. Decreased attenuation of vascular markers in one lung region, but very rarely seen in acute PE. But even if it is visible in XHS, then we must go for the CTPA, and we may find something like this. So many patients have no parenchyma availability on lung windows. And chronic disease, if you see mosaic attenuation or enlarged bronchial arteries like this, then consider chronic thromboembolic pulmonary vascular disease rather than just acute one. And the source of embolic disease, if you find some embolus inside the vessel, the source of it should always be checked, right? That source of that embolus might be central venous catheters, upper extremity venous thrombosis, or cardiac cavities like atrial thrombus. So these all need to be reported in the CTPA report. Now, in the further advancement, this society has given some recommendation by using a role of diffusion extraction computed tomography or VQ scan, right? Or spectral computed tomography or subtraction CT scan. It provides perfusion maps enhancing the detection of peripheral PE. Whenever CT scan is not possible, or sometimes if we, even though CTPA is not concluding the embolism, and our clinical suspicion is high, then we have to go for the VQ scan. That's these guidelines recommend. Useful for differentiating acute or chronic patterns, allows low iodine doses, and expected to become a routine in advanced center in future. So these are the VQ scan we may see, and these are some images, mosaic perfusion if we see, and if we have a clinical suspicion, it is better to go for VQ scans. And now role of AI. AI is everywhere. This image is created by AI. AI tools already demonstrate high accuracy for acute PE detection, acute and chronic identification, risk stratification, and these societies also recommend to integrate this AI into PE response team workflows actively now. And now the take-home messages are, CTPA is not just PE, yes or no. ESC 2024 defines mandatory items, 8 must-haves and 3 likely-haves. Always assess RV strain plus chronic signs. Artifact awareness is essential, like indirect signs, like mosaic perfusion, atoll signs, or pulmonary infarct. Structure reporting improves outcomes. And so now with this, I am concluding this. If time permits, I have 3 MCQs. Should I go or complete? Okay, so then I will conclude here, and thank you all.
Thank you, sir, for your valuable insights.
Thank you so much, Abhijit Prajapati ji, for elaborating CTPA in nice way.